Let's go ahead and get started with our webinar discussion for today. Let me welcome everyone who has joined us so far. I know more will continue to join. My name is Dr. Rachel Vreeman. I am a pediatrician and a health services researcher who specializes in HIV-related work, primarily in East Africa. I am the chair of the Department of Global Health at Mount Sinai at the Icahn School of Medicine at Mount Sinai, and I'm the director of the Arnhold Institute for Global Health. It's my great privilege to welcome everyone and thank everyone who has joined us today for this discussion about COVID-19 and global breast cancer. We are, of course, very aware that October is typically our Breast Cancer Awareness Month, and I cannot think of a better way to honor and celebrate that month than by being able to join with the global experts that we have together today. So before I introduce our speakers, which I'm eager to do, I wanted to let everyone who's joining us know that you are welcome to put questions in the Q&A box that you should see at the bottom of your screens. Feel free to type those in at any time. Towards the end of the hour, we'll take some time, probably the last 15 minutes or so, to answer questions from the audience, and we really appreciate having those. We also will be recording today's session, and that will be posted for future listening that you can also refer and circulate to anyone who might be interested. So here at the Arnhold Institute for Global Health at Mount Sinai, we've been really privileged to host a series of discussions over this year, really around a focus on COVID-19 and global health, often trying to talk about the intersections where the pandemic is having specific global health impact, and we've been considering that broadly. So today we're really eager to do this related to global breast cancer, and I could not be more happy than to welcome our two global experts today. So first, let me introduce Dr. Verna Van Dupoy. Dr. Van Dupoy is from Ghana. She is a senior consultant in radiation and clinical oncology at the National Center for Radiotherapy, Oncology, and Nuclear Medicine at Korle-Bu Teaching Hospital in Accra, Ghana. She's affiliated with the School of Health Sciences at the University of Ghana, and her interests and specialties are in breast, sarcoma, genitourinary, gastrointestinal cancers, and research into the peculiarities of managing breast cancer and managing cancers broadly in resource-constrained regions, particularly in sub-Saharan Africa. She currently serves as the treasurer for the African Organization for Research and Training in Cancer. She has served and continues to serve on many international cancer organizations and professional bodies, including for the World Health Organization, for UICC, for ASCO, ESMO, and Aortic. These are really global organizations impacting oncology care and at the leading forefront of oncology care and research globally. Dr. Van Dupoy is an editorial board member of several peer-reviewed oncology journals, and she's an author and co-author of more than 70 journal articles, book chapters, and contributions to many technical documents. So she's truly an international expert and speaker on cancers, particularly in Africa, and we're incredibly fortunate to have her joining us for the discussion today. So welcome, Dr. Van Dupoy. Thank you so much for spending this time with us on a Friday evening in Ghana. We really appreciate you joining us. Also joining us today is Dr. Ophira Ginsberg. Dr. Ginsberg is a medical oncologist and a global women's health researcher with technical and policy expertise in cancer prevention and control. She is the director of the High-Risk Cancer Genetics Program at the Perlmutter Cancer Center at NYU Langone Health here in New York City, and she's an associate professor in the section for global health at the Department of Population Health at New York University's Grossman School of Medicine. Formerly, she was based at the University of Toronto, and she was a medical officer at the World Health Organization. She continues to serve as an ad hoc consultant to several UN agencies, and her research is really focused around improving equitable access to breast and cervical cancer control globally, with funding from Grand Challenges Canada, the Canadian Institutes for Health Research, and the US National Institutes of Health. She's currently the co-principal investigator for an implementation research study to improve access to cancer genetic services through innovative primary care clinics in New York and in Salt Lake City, which is funded by the US NIH Moonshot Program for Cancer. And she's authored more than 100 publications, lots of peer-reviewed papers and commentaries. And she currently leads a new commission on women and cancer for The Lancet. So truly, we could not be more privileged to really have global experts to talk with us today about this topic of COVID-19 and global breast cancer. So in these previous webinars, we've discussed how the COVID-19 pandemic continues to impact health broadly within vulnerable populations. And of course, these impacts have continued to evolve over the course of the pandemic, both in terms of the direct impact, of course, but also the indirect impacts of lockdown, of difficulties with accessing care, and so on. So today, as I said, as we honor Breast Cancer Awareness Month, let's turn our focus to the global burden of breast cancer and COVID-19, and particularly try to focus in on the impact for low and middle income countries particularly. So quoting from an article that our speakers published, the quote was, "Each year more than 2 million women are diagnosed with breast or cervical cancer. Yet where a woman lives largely determines whether she will develop one of these cancers, have access to timely and effective diagnostic and treatment services, and ultimately survive." We know that in sub-Saharan Africa, 60 to 70% of cancers are diagnosed at stage 3 or later, so quite late in the disease state. And we know too that the 5-year overall survival rate for breast cancer patients is not higher than 60% in any of the low or middle income countries in Africa right now. We worry, of course, about what's happening with things like routine screenings for cancer with stay-at-home orders, and two, how healthcare for those with existing conditions has been disrupted during this time. I know too that we continue to see how COVID is exacerbating or really worsening existing weaknesses in our healthcare systems. All of this, I think, really having a burden for global cancer. So starting with you, Dr. Van Dupoy, I know you've outlined in previous work and studies the 3 ways that COVID-19 has been impacting cancer patients in Ghana related to their access to healthcare, increased financial toxicity, and increased mental health burdens. Could you elaborate a bit on those points for us today to start our discussion, to really give us a picture of how COVID-19 is impacting access to breast cancer, both screening and treatment, and what you see happening?
Thank you very much, Michelle. So we just realized that with the COVID, it opened up our eyes to a lot of things that we threw under the bed. We realized that people actually had to travel many, many miles to access even screening, even taking a history and being examined by the right person. This really brought to fore the problems that we have, not just for Ghana, but many other low-income countries. We could see that we're not too great on screening of breast cancer because we're still caught in the middle of between mammography and breast examination. And for us, we think it's breast examination, but who's doing this breast examination? And it has to be the healthcare personnel. They have to have some experience. Unfortunately, all of them are in the urban centers. So we could see the big gap that we have now. We have a workforce gap. Just training primary care physicians, primary care clinicians, I wouldn't even say physicians, to help with the early diagnosis of breast cancer. The answer is not really mammography for us, but just really clinical skills with a high index of suspicion. So we now realize that this big gap is just staring at us. We know we can have, it's more of opportunistic, but unfortunately this opportunistic is unfortunately in the urban areas and people can't get access to it. And this was made glaring during the COVID with the restrictions. They couldn't travel, and they didn't have enough money. I'll get to that in the next point, but we really did open this canker. In terms of financial toxicity, that was great because we realized that even though we had health insurance for mainly breast, fortunately, not other tumors, other countries do have universal coverage, but what we all forgot was that there's non-medical expenditure, which went out through the roof because of transportation. Many of our patients and their families support patients in most parts of the world. because health insurance is not that strong. And this, we have about 70% of workers being informal workers. And they bore the brunt of the restrictions.
Mm-hmm.
They lost their jobs, they lost their incomes, health insurance, those who had private health insurance. So it really did create a lot of problems for us.
Mm.
Sorry. Also, a lot of the churches, we have a lot of support from churches.
Mm.
Churches were closed, people weren't paying their tithes and collecting any money to support these activities. So more so than ever, you see people coming up and say, I don't have enough money to cover my treatments. Even though some portion of the treatments were covered by insurance, it became glaring for the first time. You really had to choose between, what to do, and you had to be sensitive to it. Mm-hmm. Or we just prescribed and went on. But
mm-hmm. Yeah, I think certainly those disruptions are many, as you're describing, Dr. Van Dupoy, especially, considering the many ways in which, much beyond, the direct impact of the virus and those who are infected with it, how the lockdowns create these financial challenges across multiple areas, and how it really does show our access is limited. I'm worried that your internet might be frozen a little bit there. We'll hope that comes back quickly for Dr. Van Dupoy. Dr. Ginsberg, could you tell us a bit about what you've witnessed, been hearing about, and even starting to see in data related to both New York City, but also thinking about your global partners? I know you work in places spanning from India to Vietnam and Bangladesh and others, and how COVID-19 has been impacting women's access to breast cancer prevention and treatment.
First, thanks so much for having us both on this webinar. And I should say that we both are involved in a couple of global efforts that are interrelated, specifically to address the crisis of cancer in the era of COVID. I'll let Dr. Van Dupoy, of course, speak for her own involvement. I participate as the co-chair of a prevention working group within an umbrella called the COVID and Cancer Global Modeling Consortium, led by Dr. Erin Carroll at the University of New South Wales, with a lot of involvement from IARC, from the WHO's Cancer Research Agency, and the task force under the, above it is highly relevant today, and Dr. Van Dupoy is involved in that. So there is a lot of data being collected. There's a lot of planning for how we are going to guide a pathway forward, because this pandemic, unfortunately, is not anywhere near over. One thing I will say is, from my own experiences here, and I do think that local and global are one and the same, we are all global, that the pandemic is unmasking, not that it needed it, but it seems to have needed it, unmasking the gross inequities in access to healthcare services for much of the populations of almost every country, really, including the United States here, of course. We're seeing this in terms of the pockets where the mortality rates from COVID have been especially high. There's great research here in the Department of Population Health, map very much to areas of poverty. And in the global domain, we see this impacting even more those vulnerable and marginalized populations in every country. India is unfortunately a very stark example of this, where people had almost no preparation to shut down, to actually go back to their villages. Maybe they work in the cities, et cetera, and people were stranded. This impacted not only, of course, access to cancer healthcare services, but even to basic food security, et cetera. In the domain of breast cancer, we saw that maybe fewer than 10% of existing screening programs, even in high-income countries, which have been mostly impacted by COVID, were able to, stay open. And that is going to have downstream impacts. We're very concerned, not only that people will not come back for screening because of fears, we need to understand that better, that's another area of research, but also that they will be afraid to present for care with an existing cancer symptom. And we've seen there's some good data coming out of the UK to show that there's already going to be an increase in number of people presenting to emergency rooms, advanced cancers that should never have to present this way.
Thank you. I think that provides a really, from both of you, a really excellent summary of the the gravity of what we're seeing, how broad the impact is. And Dr. Van Dupoy, we're so glad that you were able to rejoin us here. We understand fully how connection issues work. We'll, of course, keep going and adapt as if people have to go in or out. I think from both of you, it's clear to, you start to paint a picture of the very broad and very serious, impact that we're seeing globally for patients who are living with cancer. As you think about the current situation, how patients are struggling to access diagnosis and treatment, and also these broader impacts on their financial stability and mental health, as we're describing. I always think it's helpful if we can also add in any more individual stories. It kind of helps to balance the big picture of the data and the numbers, but also to remember the people and individuals involved as well. I wondered if either of you might feel comfortable sharing a story about the impact of the pandemic on a particular patient or colleague, or someone that in that way that you feel would be okay to share with this audience.
For me, I think there's so many of them. It really impacted. Fortunately for us in Ghana here, our restrictions was only for 3 weeks because we don't have that much of a heavy case burden. But listening from my other colleagues, treatments had to be curtailed when we're all confused. We didn't know what COVID was doing, and we stopped patients' treatment. It was really, really distressful. In a breast cancer patient who needed, it was palliative anyway, but she still needed blood transfusions, and there was no blood because people were not donating. Everybody was scared. They didn't know what to do. So unfortunately, we had to stop the blood transfusions. The truth is that it wasn't going to help her that much, truth of the matter. So this COVID actually also, apart from the disastrous effects, it makes us think through what we do and do more things that are more positive for the patients. So in as much as the patients couldn't get their treatment, she was palliative, and we're like, stop all palliative treatment. That was the initial recommendation. And she was like on her 5th line of chemo. So obviously it makes sense to stop her chemo, but then how to communicate that to her was a really big problem. And she did pass, and we were feeling like maybe if you went for the COVID, she could have continued with more treatment, but probably not. So it was a kind of like a mixed messaging. It opened our eyes to a lot of things. A lot of people got delayed because they didn't come back for their hormonal therapy. Unfortunately, again, it's right down in the urban cities, big problems in how things are done. Palliative care, people couldn't get their morphine anymore. So it couldn't get gotten, it wasn't in the districts. So how did they get their morphine? It was the whole, but luckily we didn't have that much of a burden. So this has been ironed out over the period of time. But for other countries, it was still a problem as how to manage your patients. Because I do radiotherapy, it also came up about the issue as using short fractionations. It also caused a lot of issues because you said I needed this amount of time. Why are you shortening my treatment? You have to explain that. You said I have cancer, and yet you're telling me now that the treatments might be more dangerous. I thought cancer was the most dangerous thing ever. And now you're telling me COVID is the most dangerous. So it's actually set us back many, many years behind, trying to give back positive messages about how to manage cancer. So this has been a really tough time, for us. It really has been a tough time for us. Yeah.
Sure. Yeah, and I'm so sorry. I mean, I think certainly the story you share helps to have a sense of just these many losses and how much pain you're talking about as you think about so many patients, and also the ways in which, as you said, things have been set back in terms of the work that you've done related to advocacy and education, and trying to help communities understand why you want them to come in earlier, and the care that you're asking, and then to suddenly have this barrier thrown up is really so difficult in that. But thank you for sharing that with us. Dr. Ginsberg, did you want to add anything or?
So, thank you. One thing I would say, last evening we held a webinar. I mean, I watched it, I wasn't part of it, with our colleagues at Bellevue Hospital here, addressing the issue of how the impact of the more vulnerable women here who need breast screening and who need access to diagnostic services early if they have an abnormal screen or they find a lump, have been supported by patient navigation programs. I know Dr. Van Dupoy and I both have research and and some publications in this topic. And even patient navigation has been affected because people who are the navigators themselves are contending with a lot of struggles and stresses and maybe financial and employment instability. In my own practice as in hereditary cancer management, cancer genetics, I have had several patients recently told that they have a BRCA1 mutation. And so that means they're at high risk for breast cancer, and we want them to come for screening to start now. And the screening should include X, Y, Z, et cetera. And then, oh, no, sorry, we can't access screening. This is compounding this, even a temporary shutdown as we had certainly would compound anyone's fears, especially when you think you're at high risk. And so the concern is that because of backlogs everywhere across the city and everywhere else to catch up, that some people who really need the screening a little bit more than others because they're at higher risk, and maybe the timeline from the early to a later cancer, depending on the tumor type, is more rapid. We're particularly concerned about those women coming for care. And so that's an important message. I'm sure we'll get to that at some point in the webinar today.
Sure, absolutely. I think that, the work that I do is of course largely related to HIV, but particularly, hearing and thinking about the peer navigators, that's something that, we too really have come to rely on and to try to promote and to, put in place, especially for our adolescents living with HIV, which is the group that I work with the most, both having adolescent peer navigators through the system and also adolescent peer support groups and sort of it's been so challenging to have, not only a time with, essentially that you have these increased stresses. So in many ways, like people need more help than ever in navigating the healthcare system and also coping, with the mental health challenges and anxiety and stress and worries that are going on with all of these issues. And then to have to cut off that, that kind of contact, both because it's potentially risky to be in person together, and also, we've had to sort of use more essential services first and not have some of those additional supports. It really is just such a difficult kind of spiral of challenges for people to try to navigate. I guess so sort of thinking about women who are experiencing these particular challenges and risks during this time in terms of the impact. Dr. Van Dupoy, returning to you, I know that you have done research and lectured widely about the greater prevalence of triple negative patients in sub-Saharan Africa. And maybe you can explain that a bit, but in talking with that about how there's more limited access to targeted therapies for these particular patients. Could you share more with us about that particular patient group and what those limitations, I guess maybe what they look like at baseline, so we understand what the global picture is, but also perhaps how they are also impacted during the pandemic time as well?
Okay, so triple negative cancer, unfortunately, we have a lot more than other people, but I guess that was based on the old data. But what we know now is that at least half of our patients are at least hormone receptor positive. So in effect, the number of triple negative is actually less than we thought. There was a lot of debate about maybe the quality of our testing. And this has actually been proven in the new testings, which are following protocols and double checks. And indeed, we have about half of our patients now being ER/PR positive. Okay. So hopefully we have less triple negative breast cancer, and we have about another 20% with hormone receptor HER2 positive breast cancer as well. So the number of triple negatives are not as high as we thought. All the same, we know that they have very aggressive breast cancers. They are much younger, so they need treatment quite as soon as possible. Of course, we're not using the protocols that they are using now in most of the developed countries. We have our own limitations over here and our own cultural problems as well in terms of community practice. So we tend to do, when it's a locally advanced, we follow with chemotherapy. And what happens is that when the chemos have a complete response, which is not uncommon with triple negative, the patient gets lost. because they thought it's been taken care of and they never come back for surgery. So even though the protocols say finish all your chemo before you get your treatment, in Africa it's quite difficult because culturally we have our own problems. And I probably do the same thing. It's in our DNA. So, you have to really think through and have a discussion with the patient to make sure that the patient is going to come back for treatment. They need more aggressive chemotherapies. Fortunately for most of us in Africa, they are now covered by insurance. You get the taxanes and the Adriamycin. Now, when it comes to the targeted therapies, we have a problem with cost effectiveness because of our budgets, our health spending. Generally, the whole milieu of low to middle income countries, we have a lot of competing interests. So it's quite difficult for us. And most of our patients are actually quite far advanced. So really, it might be a little bit more difficult. Our governments have not been able to commit to these treatments. The question is that how much addition do these treatments add? What do they add to our overall? For us, it's really, I know it's okay if it's a month or two for most other people looking at the broad picture, but for us, there's so many other issues that need to be tackled. So it becomes a little bit politically difficult for those who can afford it. But targeted therapies for us might be not cost effective, but then we still offer it to the patients because some patients are able to pay out of the pocket. I think it's not fair to say the outcomes are not that great or it wouldn't do anything for you. I think that is quite unfortunate. You need to discuss this with the patient and they might be able to afford it. The new drug now is Atalusima. I think Roche is just launching it in my country and it's launched in Nigeria as well. For triple negative breast cancer, the problem is that it goes with another kind of chemo. You can't use a regular paclitaxel. It has to be nab-paclitaxel, and we do not have nab-paclitaxel. So we have all these issues, coming up. And then there's a lot of, again, there's a problem with the data. So the FDA approved it somewhere in March for triple negative, and yet at the ESMO 2020, another trial didn't show that much of a difference. It's a mixed bag for us. It's very difficult for us, which in effect means that we need our own trials. We need to test these things in our environment to see what it does for us. Maybe it will actually even do better than in other regions and situations. The problem now is that it's the cost of treatment. For these reasons that I've told you, the financial toxicity is worse than it was before COVID. Yeah. And then now we're expecting them to pay for it. So we need to roll out programs. Patient support programs are really necessary in these parts of the world. Other than that, we cannot go forward. We cannot go forward with managing our patients. These patients have aggressive disease. And if you get it right the first time, they actually live long. I always laugh and say they might even outlive me, their physician. If you get it right the first time, and that's always the problem with triple negative, breast cancer. So these targeted, they are available, but the cost is our main problem. The cost is really quite heavy for us. So those are our limitations.
Sure. When we consider these things, just as you're saying, in terms of the cost effectiveness and the government priorities and what we're able to access or not access based on those and budgets and so on. Have you, in your work, I know obviously that you are quite both a national and international leader in this field. Have you had any success or kind of examples for us of success stories, or what has worked to be able to help governments to reprioritize some of these, critical needs for, how we can make cancer treatment or gain in that way a better sense of how we might gain access for our patients in these ways by shifting government priorities or impacting policy. I'd love to learn from you in this. This is something we of course think about in the HIV world and across global health very often as well.
Well, I think a lot of advocacy, because many countries like Kenya have been able to do quite well with putting a lot of their drug medications on insurance, even radiotherapy. On insurance. Of course, that also comes with its own problems because you have very long waiting lines, and even in South Africa, which is more developed than most of us, even though access to Herceptin is actually limited in the public service. So that also is a problem. It has its own issues, but how do we get it right? The good thing is that for me in Ghana, the government has actually absorbed breast cancer treatment. So we have trastuzumab on insurance. At least those who are curable get their 1 year. And before, it was a big headache trying to get patients to go on these medications. Now I don't have to write about it. I don't have to think about it. I just prescribe. And I'm very happy to do that. For metastatic diseases, at least for a year. It's just about a year. Now, how am I going to tell my patients that the year is over? Are you going to continue or not? But it's good time to generate some data. Maybe a year is better than nothing at all. So then we are developing our own solutions in how to, because the government can't pay this forever. You understand? So these are some of the issues. We need a lot of lobbying we need a lot by civil society. We really can't do it. We can just provide the data and where we think is important. I've worked on the WHO EML Cancer Medicines Consortium for a while, and we talked about essential medicine. I personally think there should be another list for low to middle income countries. It's just not realistic. Very few of them are able to get 80% of the drugs on the EML list, just because of cost and access. It's just not doable because we still have a lot of untied rules. We still have lack of electricity and water. We still have many people who can't be treated for malaria. You understand what I mean? So trying to leverage all of this together to get out with the good, it's the problem. And I don't know how best to do that. But people have done it from the developed countries. So you are the ones who can lobby for us and tell them that this is important. We can just put in and say, look, yes. So the drugs on the EML, we can try and push for them. But the question is that we actually have to look at the cost effectiveness of these drugs in context. And that is what is always missing. So we have these beautiful protocols, international protocols, but they cannot apply to us. Not that they do not, they cannot, because we don't have access to these drugs. And we also have our own cultural problems. So you can say mastectomy when the patient is going to run away because they want to keep their breasts. So you need to meet them halfway. It's very difficult. It's not just Africa, but many low to middle income countries have the same problem. So we think we need a lot of lobbying. I know people ask these questions all the time. What can we do to make this better? But it's just about lobbying. Somehow the drug companies are able to do it better than we are. So maybe we need to hide behind them to get to the government, to lobby for them to put more, things on health insurance. And universal healthcare is the way to go. The question is that how do we do that?
Absolutely, yeah.
More effective. That is the answer to our cancer crisis. Yes, it is the answer. And we have to go with cost-effective medicines. There's no point in loading it with medicines that have, so you give the higher end medicines and miss out on the lower end medicine that might have more impact. So these are some of the things that we need to really discuss and talk about. Yeah.
Dr. Ginsberg, I'm sure you have thoughts on this as well. Having spent also a lot of work, thinking
many
about
countries
and the evidence and the policy and so on. Right. What might you add or help us think about in these critical gaps?
Right, and I apologize. They seem to be doing a fire alarm testing, so I might have to put myself on mute. Great timing. As Dr. Van Dupoy mentioned perfectly, is that there is an effort, of course, at the World Health Organization, for those of you who don't know, the model list of essential medicines is what we're referring to, the EML. And in 2015, there was a major overhaul of the cancers section, and other sections, I'm sure as well, of the cancer drugs section. And some of us, myself included, had reservations at the beginning to include some of the higher cost medications like we've just been discussing. But these ultimately were included on the grounds that they had a major impact on survival. Okay. And so that is a given. It has to have, there was a criteria list of how they decided on which drugs got included, but I still had concerns because, putting drugs that are still patented, et cetera. Bottom line is I was wrong. I think I was wrong. I believe that the WHO putting out that essential medicines list with a lot of international partners and expert committees, et cetera, and the UICC, the Union for International Cancer Control, had a major role to play in that, helped us push ourselves a bit more to have those discussions with the pharmaceutical agencies and also to work with our advocates in that space, the medicines patent pool, right? The Union for Access to Cancer Treatment, which I'm an advisor on. Those are the people who understand legal frameworks, trade issues, how pharmaceutical companies, which we absolutely need, we can't have the medications without them, and of course I understand they need to make a profit, can become partners in this, in this effort to ensure that at least these drugs that have a major impact do end up on the EML, the essential medicines list, and the governments can be better informed and have some leverage to help, reduce those costs, sometimes through compulsory licensing. This is not my area of expertise, but or having, of course, there's generic companies. India is a great example. Bangladesh is a great example of countries that have a lot of in-house expertise in how to manufacture high quality generic medicines. So anyway, a long-winded way of saying that I do support this effort, but I think we have to be rational. The other piece to this is that cost effectiveness is not the same as affordability. And I think that's what we're really talking about here. I wouldn't mind at some point, though, going back to with evidence to policy. We have efforts also on the national and international scale through something called the International Cancer Control Partnership, which is an affiliated kind of group of entities, including individual academics, but mostly it's the UICC and the NCI, the National Cancer Institute Center for Global Health, that coordinates meetings with partners from the other UN agencies and other efforts to coordinate. There's an African Cancer Echo, for example, a virtual platform they've been hosting for 3 years that I participate in, where people have an opportunity from a number of countries in whatever region, in this case in mostly sub-Saharan Africa, to share their knowledge and learn from. So what's working in Kenya, or not even in cancer, maybe somebody from the ministry is represented on that call. And they've also had experience in the HIV world. What can we learn from how the advocates, did what they did to get costs down? There's a knowledge sharing is also incredibly important in breast cancer, as much as in maybe perhaps more than any other cancer that affects women. And the COVID crisis obviously has made this all the more worse. And I can share some specific examples of the other end of the spectrum too, if you like.
Yeah, feel free if you'd like with that.
We were talking before about the early detection piece to this. And what we sometimes forget is in India, for example, the government has a national strategy for 5 non-communicable diseases, including breast cancer, cervical cancer, very common in women, oral cancer as well, mostly smokeless tobacco in women, but also men with smoking as well, and hypertension, diabetes. Who is going to make this program happen? Really, it's mostly women health workers called ASHAs, accredited social health activists. They're basically the CHWs, the community health workers in India, and they, are mostly working off of incentives, not a lot, to be able to work in their own communities and educate people about breast health. And I have a project on this in Jharkhand and Uttar Pradesh. All of those women now are faced with this issue of how are we going to work in our villages door to door? Maybe this is an opportunity for technology, and to explain why it's important to come for screening, even when things reopen. They're now many people in communities are accusing these women of bringing COVID to the community. So they are in a really difficult situation. They want to do the right thing, like so many women who are also health workers who are impacted by COVID from many different angles. I just want to make sure we acknowledge that.
Yeah.
I also have something to say. That's one thing I also noticed. Thanks for that, Ophelia. We realized that we had the NGO support because we don't have that much support. So the NGOs, as the little that they could do to go around to the patients, they couldn't go onto the wards anymore. They couldn't contact the patients anymore because of COVID. So you can imagine what the gap that we have created, and they still can't go onto the wards. So you could see how much impact that's going to have on the patients. They used to get some hope, some navigation, but this is actually also stalled just because of the COVID. So the patients who are being diagnosed at this point in time are going through a really rough time.
Yeah. We hosted one of these discussions a few months ago, specifically around the issues of community health workers and CHWs globally. And I completely agree with both of you. And it was really, there's someone from our group at Mount Sinai, Dr. Madeline Ballard, who leads a coalition of organizations that engage with community health workers and community health impact in that way, called CHIC. And I think there were such critical issues, just as you've said, in terms of course, the economic impact that, we very much think community health workers deserve to be paid for the work that they're doing, but they're often very, quick to be squeezed out of budgets as there's the financial impact that they are not being counted for, as PPE or, masks and other protective equipment is so critically needed. And of course, there are shortages that they're, to access appropriate PPE is often a challenge. And then, this other issue too, as you said, of that it, often disproportionately then being women in these roles who are, are being both stigmatized, squeezed out of their work at a time when, we need them more than ever, just to connect them to the healthcare system, to, be the eyes and ears and hands where the referral center cannot be right now, especially. So I think that's a critical message to amplify as well, and important to remember that this is also that these community health workers, the ASHA and others, as they're called different things in different places, but that in global cancer too, and breast cancer too, they are an important part of our
Absolutely.
workforce.
Very important. I should mention that Dr. Van Dupoy is our co-chair with me on our new Lancet Commission on Women and Cancer. And it's not women with cancer, it's not women's cancers, it's women and cancer, to address even some of these issues in a lot more depth with our colleagues who are experts in those areas. Yeah.
I love that. I love that the two of you are co-leading that incredible effort, and also what an important focus, absolutely, as we consider the issues of equity for women broadly in this. So thank you for your work with that. I guess maybe tying into that a bit, in certain ways, I know that for both of you, mentoring and considering collaborative research and how we address both clinically and from a research perspective, the workforce and people who are engaged in this area. I know that those are priorities for both of you. I would love to hear either of you, both of you, comment on what you think we might do to accelerate or expand the pipeline of oncologists who are working on issues of breast cancer globally, or cancer for women as well.
Dr. Van Dupoy, maybe you want to go first?
Well, I don't know. I think there needs to be more collaboration between institutions. In terms of Africa, I would say we don't have that many oncologists. Of course, it's getting much better over the past couple of years, much better than it used to be. But we tend to have quite a bit more of males as well. And I think in as much as the women seem to be very focused on breast, there are very few women who say, I'm not interested in breast cancer. But I think we need to do this through collaboration, see what other people have done, because we tend to be very bogged down with the number of patients that we have. So to low to middle income countries, we really do have a problem with our workload. So finding time for research is very difficult. But I think by lobbying, collaboration, networking, you see what you can really do a lot, among the oncologists because it is our #1 cancer. So that is why we need to be dedicated to it, because we might even get it ourselves and even in our families too. So we really have to advocate for improving the quality of cancer care, the early detection to reduce deaths, and making access to drugs and other treatments very available to our women. So I think it's through collaboration and advocacy to do, and among clinicians is very important. Yes.
Right. And I can add that there is an effort in the US, if what you're also referring to, Dr. Riemann, is the expansion of interest. Now, I can tell you, having done this for 18 whatever years, it used to be like, what do you mean you're doing that? Your vacation, you're going to Bangladesh? Oh, that's interesting. Actually, we have no shortage of people expressing interest, including the incoming crop of hematology oncology fellows, a number of candidates. We've had some great candidates come through here the last few weeks for interviews, well, not physically, virtually. And some are specifically drawn because of the interest here in global oncology and, in the framing of global non-communicable diseases. Similarly, the surgery community, people going into breast surgery have a real interest. I know we have colleagues at Mount Sinai doing this as well. ASCO, the American Society of Clinical Oncology, which is, even though it says American, it's like almost half, I think, is international, has a global task force that's about to release a report led by Dr. Julie Graylow, a medical oncologist at the Fred Hutchinson Cancer Center in Seattle, specifically addressing this issue of how can we encourage those who are interested to follow, to develop, what would a career pathway look like that includes what's now called global oncology. There's a lot of women in that space, and men as well, a lot of interest in breast health from the surgical oncologists, radiation, and medical oncology communities. So I'm actually very hopeful that we're reaching critical mass now where it's not the unusual thing that you might want to do in your career, but it's something that is considered meaningful. And actually, the academic institutions have to step in as well, cancer centers, to value it, to recognize this as having some type of value that's similar to, I mean, it can include research grants, but it doesn't always, right? And so that's the relationship. The National Cancer Institute, of course, and the comprehensive cancer centers are looking at efforts in global health and global oncology as one of the things to strive for, just as much as looking at domestic cancer health disparities.
Absolutely.
So I'm hopeful about that.
I'm hopeful too. And, you know, it's been interesting as someone working in HIV, I've been so delighted to see the increased interest in how we might consider the global burden of non-communicable diseases, you know, looking beyond the infectious disease world, and how cancer treatment and care really needs to be, and of course, prevention and screening too, but really need to be part of that as well. It's been interesting to think about how we can leverage infrastructure, educational partnerships, things we have learned in HIV or other, you know, infectious disease areas to sometimes offer framework that we can build on as we try to support efforts in other areas as well, particularly thinking about the NCDs or non-communicable diseases. I want to welcome everyone who's listening to, please feel free. We'd love to have some questions entered in the box, and we'll turn our attention to those shortly. I maybe one more kind of general question for both of you as we think about recommendations for policy and practice moving forward. Do you have any recommendations you'd like to share with us today about what kind of we as the world essentially, but should really be doing, especially if you could, you know, wave your magic wands to increase awareness about breast cancer and expand access to screening and care, especially perhaps what policy changes would you like to see? But, you know, we've started to talk about this, but what would really be your priorities for improving access to care for breast cancer?
For me, I'll say a lot of cancer control plans, which include breast cancer prevention and early diagnosis, are still in the drawers of most Ministry of Health.
Exactly.
And I think this needs to be rolled out. We should lobby to have this rolled out because it really opens the floodgates, and we're going to get a lot more education. And we should consider this as part of civil education in our primary care, not primary care, but even primary education, because these kids have their mothers. And you'd be surprised, we have a breast clinic, and I realized a lot of young girls were bringing their parents. You understand? Yes. So you can see how yes, because they got educated somewhere, and the mother complained about a breast mask, and they ended up in the hospital. So it's just a way, you know, into the university. I know everybody complains, why are you doing breast education in the young people? But the impact will be great eventually down the line, because most of their mothers are illiterate and don't understand these things. So this is one way to get into the system. We need to, for us, we are very spiritual in Africa. So we need to get to the spiritual leaders to get these messages out in their churches and their herbal places, that there's a thing like that, and it can be treated when it's diagnosed early. For us, that is the problem. Early diagnosis is the problem. So how do we bridge that gap? With that, everything else is easier, because the cost of treatment is cheaper and everything. So it's about education and access to this education. We have a very high literacy rates now compared to many years ago, but it doesn't translate into health literacy. We have to bridge that gap as well. That's also going to change a lot of things.
Sure.
I would draw attention to the Breast Health Global Initiative, which is an effort also actually led out of the Fred Hutch from Dr. Ben Anderson, also Julie Graylow, and many of us who have tried to develop a strategy, a phased approach to implementing these plans, right? And then together with the International Cancer Control Partnership to provide, we all volunteer technical support. It's there. The International Atomic Energy Agency has the impact missions to help countries to also operationalize these plans, so they don't just sit on the shelf, like Dr. Van Dupoy said. But I think the main thing is for people, let's say, who are listening here in the US, to recognize that breast cancer is a global health issue. Breast cancer is a global health issue, and every minute a woman is dying of breast cancer, most women who are dying of breast cancer are living in a low and middle income country. Okay. And this is increasing rapidly with economic development. We have the data on that. We have the epidemiology. That's not the question. It's convincing people that it actually should be a health priority.
Yeah.
And the other thing I'll mention that we covered in our Lancet series a few years ago that kind of led to this commission is that, you know, we can think of breast cancer almost as a Trojan horse. If you can get breast health correct, advocacy, education, provider awareness, so they know how to do a breast exam and they know how to refer and when to refer. Referral pathways need to be also strengthened. It's the health system that will be strengthened. Pathology services, often neglected. If you don't have good pathology, all the awareness and examination in the world is not going to help. You have to have pathology as well and access to treatment. If you can do that right for breast cancer, even in a small setting, and demonstrate what's possible to your ministry, et cetera, Ministry of Finance, you can make an investment case and it can improve the care pathway for other cancers as well.
I think that's such a critical message at times. Sometimes we might feel very constrained in a specific disease area and so on, knowing that there are many diseases out there. There's so much we want to do and impact across health systems that are not working for people in the way that we hope that they would. But, you know, I completely agree that often it is the perspective, if we can invest in a sense, you know, through our efforts to create a model of care, to do research in this way that really supports those critical clinical questions and about what's working in the care system and what's not, that often brings so many other benefits along with it, that it's not just care for breast cancer that you're increasing, just as you said. For in my case, it's not just HIV management and so on, but it really builds a framework by which you can better address any of those diseases that a family might be struggling with, and over time build the infrastructure, or at least like show that it can be a model for how that kind of care and those referrals and the diagnostics and all the things needed with it might be provided. Completely agree. And I should note, we as we prepare the recording for this, we can include links to some of the references and materials and things that you've both mentioned today in terms of the Lancet series, for example, or the global initiatives. So for everyone listening, we'll make sure to include some of that with it and to also tie that into our posting of the recording session for today. I'm looking, there's a question that we have sort of bringing us back to the COVID pandemic in specific. So someone from our audience has asked, do you have an idea of how the COVID-19 pandemic is going to affect breast cancer mortality? Any window into this from what you're seeing already?
Yeah, I might just say there is a lot of data on, as I said, the closure of screening programs in the high-income countries where they were effective, and the slowness, let's say, for people to come back to screening even after they reopen. But the global, the COVID and Cancer Global Modeling Consortium, I referred to at the beginning, under which, or it says under the COVID and Cancer Task Force that Dr. Van Dupoy and I are involved in, is looking specifically at that question for a number of cancers, including breast cancer. And so this is going to have to come somewhat from, you know, real world situations, our understanding of what those delays translate into in terms of stage shift, right? It's change in the stage of diagnosis, not just presentation, but the diagnosis and access to care. So all of that modeling work's being done now, and there's already a couple of papers that are going to come out from the screening working group on that consortium. So stay tuned for that, and they will be open access.
Sure, terrific. Well, we'll look forward to seeing that then. Dr. Van Dupoy, anything you'd like to add as you consider those global figures, or even thinking specifically in Ghana as well?
Yeah, I think that the referral pathways were, even as scanty as they were actually disrupted. So a lot of people actually lost their way, you know, getting referred to the right place. Unfortunately, these right places are in the urban cities, which is wrong. So this is something also that will need to be corrected. And people couldn't come down to continue their treatments, which means because it's not decentralized. You know, so it means in a couple of years to come, we're going to have a lot of recurrent tumors. We're going to have a lot of people presenting with late diagnosis because they couldn't undergo surgery at the right time. They had to break their treatments. They didn't go for the screening mammography, even the diagnostic mammography. They couldn't go for the staging workup. They couldn't have their molecular profiling for their breast cancer because they had to be exported, you know, to confirm some of these results. So for those of us in low and middle income, this was a lot of headache, you know, for us. luckily for us, it didn't impact us so much. So things are coming back to normal. But guess what? I have a patient who needed a BRCA testing because it had to be exported because of COVID. She can't get it. You can imagine that anxiety that this is causing. So down the line, we're going to have a lot of problems. Next year, we're going to expect a lot of more advanced cancers and resistant because they had to break their treatments. And then because there was a loss of faith in the health system, all of a sudden cancer is not important. A lot of people ended up with alternative medications. So they gained the upper hand. And then the people are going to have more trust in that because they are local, they just have to walk there, they don't have to travel, and then they don't have to spend that much money. And they're like, you see, you didn't need the treatment after all, I could treat you here. Mixed messages, very confusing. So that also will translate in more advanced cancers coming out in the next couple of months and years. So we are going to be ready for a tsunami. Yes.
Yeah, and I think it is such an interesting, we have these challenges of, there's the actual disruption in the system and then this ongoing concern that, even once we're saying we're open, please come, things are available, trying to overcome that. And also what you said, the level of trust, I think especially, I think we're certainly feeling this in the United States as well, where, where our health systems have failed people and especially have failed some very vulnerable communities, and then as well as our government responses and things, and then it's an even greater burden to say, oh, but please trust us in our treatments and what we're recommending for for your cancer screening or cancer treatment. Trust us, for these other vaccinations, when when all that we've done in the pandemic, it might seem, is that we've had created reason for mistrust in those ways.
Yeah, that's very concerning.
Absolutely. Yeah, absolutely. Well, let's close on a more positive note, I guess, recognizing that there is so much that is weighty, and I do, I think it is important that when we have awareness events and months and times to to consider the weight of this. And I appreciate everyone walking with us through these challenges and the weight of this globally today. But let's look forward a little bit. I would love to hear from each of you what gives you hope as you look to the future and think about what might bring us towards better outcomes for breast cancer and better, overall health when we consider cancer globally.
Looking forward, I think a lot of issues have come to fore in about what we do for breast cancer. For us, definitely, the first thing is to decentralize screening, decentralize diagnosis, educate more primary care workers on how to create awareness, how to do clinical breast exam, which is what we do. These are things that we never really thought about. So there are some silver linings to COVID-19, and there's going to be, the UICC is also coming up with a paper on that, on the silver linings from what we've learned from the pandemic. And also we've had to come back with all these treatment protocols that are more supposedly spending less time in the hospitals. So definitely it means spending less time financially also to cover these patients. So the governments are going to save more money if truly the outcomes are equal. And there was evidence, all of them were evidence-based to show that they were equal, but why didn't we adopt them? So that is my biggest question, both all the way from systemic therapy through to radiotherapy. I'm like, so what was missing here? Why didn't we adopt these cost-effective measures that have the same outcomes? It will save the patients money, not just the governments, but to save the traveling time, their anxiety, going back to work and all that. These are things that I think would improve access. So your treatment is only for 5 days for breast cancer. Why not? The treatment is for 5 weeks. Man, I'm going to lose all that money coming back and forth. These are things that we didn't think through. And I think this is going to improve our outcomes. It's going to improve compliance, which is what we have in these parts of the world. Compliance to care was very difficult. And then more of oral therapies. We don't have more of the targeted oral therapies, but the basic hormonal therapy we do have. And I think we weren't making use of that. Even though we had a molecular profiling, we still thought giving IV chemo was the best outcome, even though you were hormone receptor positive. But now it's like, look, maybe keep the patient out of the hospital. You don't have to follow them up so frequently, which we were doing, which we were just burning out ourselves. But we could do this online. things are much better. I mean, I could talk to you for a whole hour on the internet, which wasn't there before, but we can do so much more with our WhatsApp, with follow-up using our nurse clinicians. We are old-fashioned, we're not used to using nurse clinicians, but it's time we do. So this will open the horizon. More people are going to have access to healthcare practitioners, and then I think the overall outcome may be much better than we think. Maybe not after the tsunami. I think we'll find a better way of improving access to care across the cancer care continuum. They don't have to travel for their morphine. You can do this online. You can network with other pharmacies. It'll make a whole lot of difference, not just for Africa, but a lot of low to middle income countries that are having this problem.
Thank you. Thank you. Yes, there is so much there to be hopeful for, that we are learning from, despite the tsunami, as you said, that is there. Dr. Ginsberg, what gives you hope as you look at this?
Well, it's hard to add to that. I would just say I concur completely with everything that Dr. Van Dupoy just said. And I would also put a shout out for the use of telemedicine and any kind of virtual platforms that we're able to use now that used to be, well, really, can we really do this? Well, now we have to, and so we're doing it. Notwithstanding the concept of Zoom fatigue, which I think many people are having, we've been able to make our whole genetics program, we were virtual within, before the shutdown, because we could see it was going to happen. And we innovated quickly to, a new model of care. But the same can be said for the use of the ECHO platform I mentioned with the Cancer Control Partnership led by the NCI Center for Global Health and UICC. People are coming together, recognizing that actually a lot of the gains we've made in global cancer control are at risk now because of the obvious strains on the system. And so we have to be more innovative, and we kind of have to keep communicating with each other and find better ways together, just as Dr. Van Dupoy was saying. I think this is maybe a turning point for our own community in global oncology in a positive direction. It has to be.
Wonderful. Well, thank you so much to both of you for being with us today. I've really appreciated this discussion, and it's really illuminating to think broadly about how, for such a big area of disease focus, how both the impact and as we've talked about, the pain and loss and multiple challenges are there, but also too how there can be innovations, shifts in what we might think about targeting at a policy level, at a advocacy level in that, and as health systems globally that consider how we might respond in these ways. So thank you so much again to both of you. As we've said, the recording of this session will be posted on our YouTube site, where we have the COVID and global health recordings posted if you're interested in any of the previous ones. I thank everyone who's been able to join us today from all over the world and listening and participating. Please, of course, feel free to also circulate that recording if you find it of interest to your colleagues. Next month in November, we're going to be having Dr. Erin Carroll, who is a health services researcher and public policy and health policy expert nationally, as well as a frequent and opinion columnist for the New York Times, revisit with us the impact of the election on global health and on the COVID-19 pandemic. We're doing that towards the end of November. I think it should be an interesting time, no matter what is happening related to the American election and what we think about related to COVID and global health in that context. Again, thanks to everyone for joining so much. So take care. Goodbye.
Thank you.
Thank you.